Kawasaki disease by Lucy Rubin and Dr. Lisa DiPietro. Learning objectives. By the end of this video, the learner will be able to explain the pathophysiology of Kawasaki disease, recognize the clinical features and diagnostic criteria, describe the potential complications, and discuss the important steps in managing a child with Kawasaki disease. Introduction. Kawasaki disease is an acute systemic vasculitis of children. Approximately 3/4 of children presenting with acute disease are younger than age 5, but Kawasaki disease can occur in older children as well. Boys outnumber girls 1.3 to 1, and children of Asian ancestry are at highest risk. The cause of Kawasaki disease is unknown, although most experts believe that Kawasaki disease reflects an immune response to an unknown infectious trigger. Kawasaki disease arteritis particularly affects the coronary arteries, and coronary aneurysms are caused by vascular infiltration first of neutrophils, transitioning to large mononuclear cells, along with lymphocytes and plasma cells, causing a weakening and dilatation of the vessel walls. Clinical presentation and diagnosis. The clinical presentation of Kawasaki disease can be remembered by the mnemonic crash and burn. C is for conjunctivitis. R is for rash. A is for cervical adenopathy. S is for strawberry tongue. H is for hands and feet, which is to say swelling and erythema of those parts. B is for burn, which is to say fever. The diagnosis of classical Kawasaki disease can be made clinically based on the following criteria: fever for 5 or more days and at least 4 of the 5 clinical features from the crash mnemonic. Conjunctivitis, which is typically bilateral and non-purulent. Rash, which is a polymorphic rash that can be seen on the trunk, extremities, and groin. Adenopathy, which is cervical and unilateral, with the node being at least 1.5 centimeters in diameter. Strawberry tongue, or erythema of the tongue with prominent papillae, as well as erythema of the oral mucosa and lips. Changes in the hands and feet, which may include swelling and erythema in the acute illness. Periungual desquamation occurs 2 weeks after fever onset. Patients who have less than 4 of the 5 principal clinical criteria who have fever with coronary abnormalities can have incomplete Kawasaki disease. For these patients, you can follow the American Heart Association algorithm for evaluation of suspected incomplete Kawasaki disease. If a child has a fever for greater than or equal to 5 days, with 2 or 3 of the principal clinical criteria, or if an infant has a fever for greater than or equal to 7 days without another explanation, the next step is to assess laboratory tests. C-reactive protein, CRP, and erythrocyte sedimentation rate, ESR, are markers of inflammation. If the CRP is greater than or equal to 3 milligrams per deciliter and/or the ESR is greater than or equal to 40 millimeters per hour, assess for anemia, thrombocytosis, hypoalbuminemia, elevated alanine aminotransferase, or ALT, leukocytosis, and white blood cells in the urine. If the patient has 3 or more of those findings, or has a positive echocardiogram, treatment should be initiated. In the absence of those features, the patient should be monitored clinically with repeat laboratory testing if the fever persists. A patient with Kawasaki disease is often very irritable and difficult to console. In addition to the classic signs and symptoms, they may also have involvement of the musculoskeletal, GI, GU, respiratory, nervous, and cardiovascular systems. The most concerning potential complication of Kawasaki disease is coronary artery aneurysm, which occurs in about 25% of untreated patients. With timely treatment, fewer than 5% of children with Kawasaki disease develop aneurysms. Given the wide range of potential clinical findings, a comprehensive physical exam is essential. Assess the general appearance of the child. Is he irritable? What are his vital signs? Does he appear dehydrated? Inspect the skin, including the extremities and the perineum. If a rash is present, describe it. The rash of Kawasaki disease is most commonly maculopapular, but may also be morbilliform, targetoid, or scarlatiniform. It is never vesicular. Are the hands and feet edematous? Are the palms and soles erythematous? Is there any ischemia? Complete a thorough HEENT exam. Is there conjunctival injection? Are the lips red or cracked? Is the tongue red with prominent papillae? Is the oropharynx erythematous? Is there lymphadenopathy, and if so, is it unilateral or bilateral? How big are the nodes? Are they tender? If the lymphadenopathy is diffuse, this is more suggestive of a viral illness. It is also important to perform cardiac, respiratory, and abdominal examinations, although the findings may be nonspecific for Kawasaki disease. Management. All patients with Kawasaki disease should have an echocardiogram to look for coronary aneurysms or dilatation, as well as other potential cardiac complications such as pericardial effusion, valvular regurgitation, or decreased left ventricular function. While laboratory tests aren't necessary for diagnosis, they can be helpful if the diagnosis is not certain. Several abnormalities may be present, including anemia, leukocytosis, thrombocytosis, elevated CRP and ESR, hypoalbuminemia, elevated ALT, sterile pyuria, and CSF pleocytosis. The mainstays of treatment for Kawasaki disease are intravenous immunoglobulin, IVIG, and aspirin. IVIG, which contains antibodies from donated blood, should ideally be given as a one-time dose within the first 10 days of the illness. It works as an anti-inflammatory to decrease the risk of aneurysms, as well as to lower fever. Moderate to high-dose aspirin is often given until the patient has been afebrile for 48 to 72 hours, followed by low-dose aspirin for 4 to 6 weeks or until aneurysms resolve. Those patients who develop a fever after 36 hours post-IVIG treatment without another explanation can have refractory Kawasaki disease and may be retreated with a second dose of IVIG or other anti-inflammatory therapies if Kawasaki disease is still the likely diagnosis. Appropriate follow-up for uncomplicated Kawasaki disease includes repeat echocardiography at 1 to 2 weeks and 4 to 6 weeks after treatment. For patients with coronary artery aneurysms, cardiologic follow-up and treatment, including antithrombotic therapies, are tailored to the severity of coronary involvement. Summary. In summary, Kawasaki disease is an acute systemic vasculitis of childhood that presents with conjunctivitis, rash, lymphadenopathy, changes in the oropharynx, and changes on the hands and feet. The most concerning complication is coronary artery aneurysms. An echocardiography should be performed on all patients. Treatment includes IVIG and aspirin. Patients with always normal coronary arteries have no increase in cardiovascular mortality compared with the general population. Children with coronary artery aneurysms, even those that remodel to normal, require lifelong follow-up. Thank you for watching this video on Kawasaki disease.